Hi everyone, my name is Sathish. I'm a postdoctoral fellow from McMaster University in Canada. Topic of my presentation today is cost effectiveness of a peer support lifestyle intervention for the prevention of type 2 diabetes in India within trial analysis of the Kerala Diabetes Prevention Program. As we all know, type 2 diabetes is a major cause of death and disability worldwide, particularly in low and middle income countries such as India. Several randomized control trials have clearly shown that lifestyle intervention can reduce diabetes incidence and can improve cardiovascular risk factors. We also know from these trials that lifestyle intervention for diabetes prevention is generally cost effective. However, this is based mainly on studies conducted in high income countries, which may not be generalizable to low and middle income countries. And data from low and middle income countries are quite limited. So we undertook this cost effectiveness analysis of a diabetes prevention program conducted in the Indian state of Kerala called the Kerala Diabetes Prevention Program. The trial was a cluster randomized control trial implemented in 60 communities which were randomized equally into an intervention group or a control group. Participants were aged 30 to 60 years, were identified using a two-step screening procedure, a diabetes risk score followed by oral glucose tolerance test. So participants' high risk were based on a high diabetes risk score and they did not have diabetes on an OGTT. Participants in intervention clusters received 15 group sessions, mainly delivered by trained lay peer leaders who were identified from within the group and trained by the program staff. There was also a couple of diabetes prevention education sessions from experts in diabetes, physical activity and dietary areas. Intervention objectives were to mainly increase physical activity, to promote healthy eating habits, tobacco cessation, to reduce alcohol intake, and to maintain ideal body weight. Control group received a health education booklet at baseline on standard lifestyle change advice. For this analysis, we considered costs from a health system perspective and also from a societal perspective. For health system costs, we consider screening costs, intervention costs, and healthcare use costs. Healthcare use costs included OP visits, IP visits, drugs, and diagnostics. For societal costs, in addition to health system costs, we considered non-medical costs for attending group sessions and also that are related to healthcare use. We also consider indirect costs which resulted from lost productivity due to illness. Unit cost estimates were obtained from WHO choice figures and also from self-reports from participants. The cost estimates are expressed in 2018 US dollars. In terms of effectiveness, we assessed effectiveness in terms of quality adjusted life years as recommended by several guidelines. But we could not analyze effectiveness in terms of diabetes incidence because the intervention was not significantly effective in reducing diabetes incidence at 2 years, although there was a 12% relative risk reduction. And this analysis was performed with a 2-year time horizon. Coming on to results, we recruited slightly more than 1,000 participants, distributed quite similarly between two groups, all 60 clusters, and nearly 96% of participants were followed up at 2 years. Baseline characteristics including healthcare use and utility values were similar in the two study groups. If you look at table 1 is about mean cost per participant over 2 years by study group. Coming on to screening costs, screening costs are equally distributed between two groups with an average cost of $29 to recruit one participant. Intervention costs are unsurprisingly higher in the intervention group with an average cost of $24 to recruit to intervene in one participant in the intervention group and less than $1 to intervene in the control group. With regards to healthcare use, healthcare costs were lower in the intervention group by nearly $20 compared to the control group. From health system perspective, costs in intervention group are slightly higher by $2 compared to the control group. However, this difference was not statistically significant. costs from a societal perspective again were not significantly different between two groups, although it was slightly higher in the intervention group by $6, which is quite similar to what we see with the health system costs. When you look at figure 1 shows the effects of intervention on QALYs. QALYs were consistently higher in year 1 and year 2, and over a period of 2 years, there was a significant increase in QALYs by 0.04 in the intervention group compared to the control group. Figures 2 and 4 is a cost effectiveness plane showing the distribution of 1,000 bootstrap cost and QALY estimates distributed in 4 quadrants in the plane. You can see majority of the bootstrap estimates lying in the southeast quadrant, which is on the top down on the right side of the plane, which indicates that the intervention is likely to be cost saving. And the rest of the bootstrap estimates were lying in the northeast quadrant, which is on the top right quadrant of the plane, which indicates that the intervention can be effective at a higher cost. Figures 3 and 5 shows the probability of the intervention to be cost effective at different willingness to pay thresholds. Our intervention was found to be cost effective with a probability of more than 97% from both health system and societal perspective at a willingness to pay threshold of less than 3 times India's GDP per capita, which was recommended by the World Health Organization. So to conclude, health system and societal costs were not significantly different between two study groups. However, the intervention was effective in increasing QALYs by 0.04, which is similar to what we see in other trials, USDPP for example. And it is very likely that the intervention will be cost saving in the longer run because healthcare costs were declining in the intervention group over a period of 2 years, while they were increasing in the control group during the same period. So if the trend continues after 2 years, it is likely that the intervention will be cost saving in the longer run. There is a plan to follow up our cohort participants at 7 years to look at the long-term effectiveness of the intervention on diabetes incidence, cardiovascular risk and cardiovascular risk factors, and also cost effectiveness of the intervention at 7 years. Thank you for your attention.